I, Dr. Rishikesh, feel privileged to welcome you all on the behalf of the entire team at MCure Pharmaceuticals. We at MCure are proud to present Cardio Colloquium, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected moderator, Dr. P.B. Jayagopal sir. Sir is Director and HOD and Senior Interventional Cardiologist at Lakshmi Hospital, Palakkad, Kerala. Sir is Editor-in-Chief, Journal of Indian College of Cardiology and Global Chair of American College of Cardiology for Global Heart Attack Treatment Initiative. Sir is past National President of Indian College of Cardiology and President of CSI Kerala Chapter, Heart Failure Council member of Asian Heart Society. Sir has participated as Principal Investigator and National Coordinator of the Heart Failure Registry by Indian College of Cardiology. Sir is Executive Committee member of the Heart Failure Association of India and Society for Heart Failure and Transplantation. Sir is involved in landmark clinical trials like CREATE, Kerala ACS, ACS Quick and HF Quick and AF registries. Sir has 72 publications in peer-reviewed journals to his credit, and sir has more than 32 years of interventional cardiology experience and performed more than 28,000 procedures till then. Thank you, sir, for accepting our invitation to be the esteemed moderator for today's program. It is an honor for me to introduce our expert panelists for today. We have Dr. Sai Ravi Shankar, sir. Sir is HOD and Senior Consultant Cardiologist at Aster Prime Hospital, Hyderabad. We have Dr. Jabir Abdullah Kutti, sir, Senior Consultant Cardiologist and Director of Clinical Research at LISI Hospital, Ernakulam. We have Dr. Sridhara G, sir, Consultant Cardiologist and Cardiac Electrophysiologist at Manipal Hospital, Bangalore. We have Dr. Sampath Kumar, sir, Consultant Cardiologist at KMCH Specialty Hospital at Erode, Tamil Nadu. Thank you, esteemed panelists, for joining today. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the session on optimal selection of RAASi in post-MI patients by our esteemed moderator, Dr. P.B. Jayagopal, sir. The meeting will proceed further with the panel discussion, where Dr. P.B. Jayagopal, sir, will drive the discussion with the panelists. I request audience to put their questions in the comment box so that we'll take up those questions in the end. Now, I would like to invite Dr. P.B. Jayagopal, sir, to deliver keynote session for today. Over to you, sir.
Thank you, Rishikesh, and thank you, the team MCure, for having invited me to take part in this webinar. So I think the topic that has been actually the topic for discussion this evening. Are you able to see my slides?
Yeah. Yes, sir. Yes.
Yeah.
So please make it full screen.
Right. So it's mostly on the RAS inhibition post MI, which I mean, of course, for a treating physician, it's important to understand. But I think these are concepts which probably has evolved more than 30 years of cardiac practice way back when this got introduced, when the RAS inhibitors got introduced. And then I think this was perhaps one of the real game changers in the management of post myocardial infarction scenario. I mean, so much to really emphasize that, you know, this has stood the test of time, and even today, I think this becomes one of the guideline-directed medical therapy for post-MI patients, whether you have a heart failure patient or whether you have even a patient with normal LV function, which perhaps we can take at the discussions at the end of the presentation. So I think I'm asked to present a few things about the post-MI RAS inhibition, which I am sure most of you are aware of. This is a repetition of things which have evolved, as I had mentioned earlier, over the last 30 years. So I think first and foremost, I think we go in an order. We discuss about one of the key things, whether it's a question is whether RAS inhibition means, is it a ACE inhibition, is it an angiotensin receptor blocker, or maybe whether it's a new drug, the wonder drug, which has actually changed the heart failure therapy and probably the best available medication for all heart failure patients, and which has really given a new lease of life for many patients. In the post-MX scenario, we'll also discuss how ACE inhibitor stands out. In fact, when you need to discuss all this in the context of new molecules, there is something to really understand today why we prefer ACE inhibition. And finally, we'll also discuss what the guidelines really suggest. But I think just before we start this process, in fact, me and Jabir, we were involved in a lot of registry, a lot of prospective studies, and I think we've been fortunate to get very real good team across the country to participate in this. And one of the things that we really looked into is actually the prescription pattern in post-MI scenario. In fact, we captured data on more than 1,000 patients in 5 centers in South India, including Lizzie, our center, Kupadama Naidu in Coimbatore, and Bangalore, Jayadeva, huge numbers. So we had actually data on 1,020 patients, and I must tell you, the ARBs in that context, we found that to our surprise, that telmisartan was preferred by cardiologists. We are not talking about physicians. In fact, when we looked at the data, it was really something which was very an eye opener. So the question is, what is the evidence of ARBs? So I think the whole concept came because the angiotensin receptor blocker. I still remember the days when captopril got introduced into the market. In fact, whenever we used to prescribe the first dose of captopril, we used to make the patient sit in the outpatient. Basically because the first dose hypotension was a major factor. In fact, if you look at all the trials, the SAVE trial, the initial problem with captopril was the first dose hypotension. There was a worry whether this would really be deleterious in the context of myocardial infarction. Then, of course, IV enalapril was tried. And there again, the problem again was that there was real hypotension, and that was so. But over a period of time, I think we have data, which is what we're going to discuss at the end of the session, as where ACE inhibitors remain. So the concept is, if ACE inhibitors work, why not ARBs? Because ultimately the angiotensin receptors have to be blocked, and that's where the 2 trials really came in. In fact, these are the really talked about trials, though we are talking about trials about 20 years earlier. One is Optimal, which had about more than 5,000 patients. And of course, the Valiant trial, which had a huge number, Valsartan, is so the Lasartan. So the benchmark was actually trying to compare the efficacy with captopril, which is a proven therapy. And so that is what really was important. So the subsequent trials also looked into the larger trial, looked into Valsartan. And because, we have this molecule, which really was favorable in the context of post-myocardial infarction, and then they actually compared with captopril, and also they came to the understanding, which is perhaps very important today. We know that we don't combine an ACE inhibitor with an ARB, and this again, the same expected results, that they had more adverse effects, particularly renal side effects. So to talk about the Optimal, we are trying to probably refresh our memories, where the losartan was compared to captopril. And they found that there was no non-significant difference in total mortality in favor of captopril. And the idea came in that even if you have the ARBs, ACE inhibitors should remain the first choice after a complicated myocardial infarction. And as a rule, losartan cannot generally be recommended. But I think today, the moment you have a heart failure, probably it is different, because we know that in the heart failure scenario, there are 3 approved ARBs. One is losartan, the other is valsartan, and the third is candesartan. Of course, it's available, but very difficult to get in our Indian scene. It's a very cheap drug, and these are the agents tried. Now, similarly, about valsartan, which is other approved drug in heart failure, in acute myocardial infarction, if you look at the graphs, you find that there is nothing to choose between them. The mortality from any cause and cause-specific was similar in the 3 treatment groups. And also the rate of other secondary endpoints, like, when you talk about myocardial infarction, we are talking about recurrent events and hospitalization for heart failure, which is again not very different in the 2 groups. So that's perhaps the data that we have on ARBs. But I think more interesting when the paradigm trial came with a bang in 2014, and then that really changed the scenario of heart failure practice. So it was believed that in the context of post-myocardial infarction, this would make a significant difference. And so the concept that if it would work in heart failure, why not post-MI when you have an LV dysfunction? And that's where Dr. Pfeffer and the group, they tried this, and which was known as the Paradise MI. But mind you, there were a lot of criticism about this, because this was done in COVID times. and they did not really run in for a long time. It was prematurely terminated. But all said and done, it's interesting to note that this group of patients who had a myocardial infarction within 5 to 7 days, and with LV dysfunction and a proven EF of less than 40%, either with that or a pulmonary congestion, or plus any other risk factor for enhancer for that matter. For example, if you were elderly, you had an atrial fibrillation, EF significantly low, less than 30, EGFR on the lower side, diabetes, prior myocardial infarction, and STEMI without repo. All these were the major inclusion. It's interesting that these are the category of patients we would definitely think in terms of ACE inhibition, which is the accepted guideline today. And then, of course, they ruled out prior heart failure because, it's already proven therapy. So somebody is using that. It's not wise to involve them. And if they were clinically unstable, for example, I told about the captable hypotension. So somebody has a hypotension. This is perhaps not the kind of patient you want in there. And again, significant renal dysfunction, stage 4 renal disease. So then they were given an equal number of patients. If you could look at it, the sacubitril/valsartan had about 2,830, almost a similar number with ramipril, fairly high dose of ramipril from Indian standard, 5 milligram BID. And they looked at the primary endpoints was the MACE, the 3-point MACE, like the cardiovascular death, hospitalization, which is again an endpoint today, and outpatient development, worsening heart failure. And the secondary endpoints were cardiovascular death or first hospitalization. And when they looked into it, they found that let's say the hypothesis was that the sacubitril/valsartan would work well. In fact, it did not. And what you see here in red is that the incidence, all the primary outcomes actually was significantly low with ramipril. So the primary outcome with sacubitril, it did not make a statistical significance. It was about p-value was 0.1, you would have expected a remarkable difference, which did not happen. Again, if you look at the cardiovascular death, heart failure, hospitalization, there might have been a tendency, but then it did not really score over ramipril. And more importantly, in fact, what is even more distressing is that I mentioned about hypotension, which is one of the major problems. We all know that as interventional cardiologists, when you do a primary angioplasty, it's not just a reperfusion, but I think the hemodynamics are equally important. So if you have a hypotension at the end of your procedures, or let's say you have to keep them on inotropes, for whatever purpose, the sympathetic overactivity starts creeping in with you with inotropes. So these are the sort of patients who do not do well. And more importantly, in fact, this is what I see in my practice also. Some of them with heart failure, they have a remarkable improvement with sacubitril/valsartan. But just like what you have with ramipril, a good percentage of them, they come back to you with cough, which is again because the bradykinin inhibition is gone. There is circulating level of bradykinin in the system, and the same mechanism which produces cough with ACE inhibition, it becomes very relevant. So I think apart from that, the other things did not make a substantial difference. So these are the two things which stood up. And finally, to summarize, the PARADISE AMI trial did not result in a significantly lower rate of cardiovascular death, the primary endpoint, either heart failure, hospitalization, or outpatient worsening. And the safety and tolerability was almost comparable, except the side effects which I had mentioned. So I think it was not a positive trial, but then people felt that perhaps it was a little too early, and the kind of patients who were really involved in them were perhaps more sicker patients. And again, at the end of during the COVID times, perhaps a lot of centers and larger data could not be cooled, and this could not be continued for a long time, because all of us know, and I'll share you this data later on with ramipril, the legacy effect, just like what we talk about the legacy effect of chlorthalidone, when you use it as an antihypertensive, 25 years, 30 years down the line becomes evident. Likewise, there is a concept that the legacy effect of ramipril comes over a period of time. So I think fairly shorter follow-up, and that's perhaps the reason. So a lot of things came out after this meeting. The PARADISE AMI ARNI doesn't surpass ACE inhibitor, so the benefit was questionable, and today it is not really recommended. So I think in the context of AMI, in fact, I would always in my practice withhold this for the first 3 months, and once if you have an LV dysfunction, or let's say they get into the phase of a chronic therapy, at that point maybe switch it over. So that's perhaps the take on ARNI. But then what is the evidence for ACE inhibition? Well, I think the 3 trials which showed not just long-term but short-term, the 3 trials were the SAVE, which was done in an EF less than 40%. All of you know this. I don't really have to run that. There, a trial where ramipril again was used, and the trace were trazodone with a wall motion score in EF less than 30. Fairly sicker patients were done. And the short-term were the consensus DC3 and IS4. I'll just run through the slides because it's important what was said and done historically. This has been the trial which has pushed the ACE inhibitor into therapies. For example, the SAVE survival and ventricular enlargement, they looked at EF less than 40, mean 3 to 6 days. Fairly good number of patients. Captopril, and it gradually stepped up to maximum 50 TID. And the captopril group, if you look at the graphs here, showed a significant reduction in mortality and recurrent MI. And not only that, the LV remodeling, which is what we are worried about, it had an effect on that. And this is seen whether the patient had a lytic therapy or whether the patient was not reperfused, and also whether the patient was on a beta blocker or not. So I think this stood out, and that's perhaps the most important thing which came out, and that's really was a cornerstone of the therapy post-myocardial infarction. Subsequently, in 1995, the TRACE trial, tandalopril, again, somebody had a wall motion score less than 1.2 and randomized again the same time. Fairly large follow-up, and at 25%, exactly the same kind of a reduction in mortality, 15% reduction in recurrent MI. And of course, more importantly, what we are seeing today with the sacubitril valsartan, there was a tendency towards reduction in sudden cardiac death. That's not the beta blockers. Today, we know the two major trials post-MI, the reboot trial, everything has come out. Beta blocker perhaps may not be useful in somebody with a normal EF. Maybe in LV dysfunction, it has an effect just like this, reducing sudden cardiac death. So it's important to understand this. And of course, the other evidence is larger ISIS for 1995, where captopril was effective in reducing the 5-week mortality. And in fact, I was really fond of this drug, the lisinopril part, because the good thing about this drug is a long-acting drug, once daily, 24 hours after the MI, very effective in reducing the mortality and ventricular dysfunction. And I still believe in this drug because the long-acting nature, just like your bisoprolol, makes it one of the favorite drugs in the post-MI. And of course, the CCS1 anterior myocardial infarction, which again showed that the captopril group had a lower mortality. So I think substantial data to back the point, and that's how this has really come in. But I think, again, the major important thing is what kind of ACE inhibitor. Today we know, in fact, the survey, which I just didn't want to spell it out, when we took it, when we did on this 1,000 patients, we found that ramipril was the preferred agent by the cardiologist. And then what really came out is that, the AIR is 1993 acute reinfarction ramipril efficacy with transient or persistent AF. Again, fairly large number, around 2,000 patients, followed up for about a year and a quarter. And ramipril showed a 27% reduction in mortality. Again, recurrent MIs were less in stroke at the end of 6 months. Again, proving the point that ACE inhibition was effective. And just as I had mentioned the legacy effect, this is too early because this is just an extension study, which was carried out for about 5 years on about 603 patients. Again, the beneficial effects, we saw that it started early after MI and then continued over a period of time, despite discontinuation of medication at 1 year. And treatment of 9 patients with ramipril for an average of 1 year will result in 1 additional survival for 1 year. So I think this is a significant data for us to understand the efficacy of this molecule. And of course, the long-term effect, which is what I was trying to tell you, the legacy effect, when you follow this up, approximately duration 30 years, to assess the long-term magnitude of impact of length of survival after treatment, when compared to placebo, that is what we call the ramipril survival ARS group. Again, the median survival time was 8.3 years versus 9.6 in ramipril group. Just like we talk about the guideline-directed medical therapy in heart failure, when you say that the all 4 pillars are there, and for a person at the age of 55 years, he gets an extension of 8 years. 80-year-old gets an extension of 3 years. I think this is probably the idea. Similar things were given from these studies also. The survival across at 14 years from the time of randomization, and the life expectancy were greatest at about 15 years. So I think this is what I was mentioning about the legacy effect, and that's very evident. And in fact, if you start trying to analyze which group of patients did well, you can find from the graph that the elderly, for example, a significant difference. The patients with the previous myocardial infarction, yes, again, more effective, some history of heart failure, hypertension. In fact, if you want to treat somebody with hypertension and post-MI, it's always ACE inhibitor, and that's been it stood the test of time. Those patients with angina, and again, those patients I mentioned earlier, elderly group also did well. So the results showed a substantial survival gain with ramipril. Overall, for every day a patient received ramipril, on average, his life was extended by a further day, which is really significant. And the relative risk of survival for patients with diabetes increased by about 50%. So the results were, we are fairly clear that elderly, those patients with an extensive infarct, heart failure, or hypertension, when they benefited more from ramipril therapy, and that's what was just seen by this legacy study. So the conclusion is that treatment with ramipril for about a year, when started early, actually results in a survival benefit with the extension of additional life of 1 year. Now, having talked about the ACE inhibitor, now what has happened to the current guidelines? I think this is a very important slide for all the treating physicians to understand. In fact, I always used to present this slide in most of my talks. If you have somebody with an MI, when do you start ACE inhibitor? In fact, the first drug that you start is ACE inhibitor, because if you start early initiation of ACE within 24 hours, 40% survival benefit. In fact, we started our practice. I started in era when reperfusion therapy was not available. In fact, the first intervention I did in myocardial infarction, it was all medical, and the intervention was metoprolol in acute myocardial infarction, Miami. So we used to administer IV metoprolol for every patient, irrespective of the location, and then we found that there is a substantial benefit. And then this was a drug which was favored, and subsequently the ISIS-4 results also came in. So beta blocker became the standard indication. But then the large trial from China showed that early beta blockade, it will blunt the sympathetic effect and lead to hypotension and excess mortality. So that is the reason why you say avoid beta blocker the first 24 hours. And then, of course, early introduction of aldosterone within the first 7 days. And finally, when you discharge a patient, titrate the dosage of ACE inhibitor to maximum tolerated dosage. And that's the way things are. That is the post-MI state. And this is exactly what is given by the guidelines which came in post-myocardial heart failure. ACE inhibitor should be administered within 24 hours for an E of less than 40. And it should produce a significant, the 40, this thing becomes very evident, significant survival benefit of about 40%. And that's why it has become the class 1 indication as per the 2020 ESC guidelines for acute. Of course, the new ones have come in now. The ACC, AHA, again, high-risk patients, again, recommend the same thing for ACE inhibition. So I think I would like to stop now. I think I hope I have not exceeded my time. And I would like to invite all our esteemed panel members to take part in the discussion. So with that, I would again go back to this thing. We probably can take the questions one by one. I think.
Dr. Jayagopal, of your studies,
Yeah.
You told the telmisartan was commonly used by cardiologists post-MI.
Correct, you're right. In fact, yes. So the ramipril was this. So we looked at both ACE inhibitors and ARBs.
Yeah.
And so what was this? Was really actually
this is only a pen habit, or is anything to do with actually cardiac failure?
Yeah, Dr. Sampath, if you can see all of our, the panel members on camera, I think it becomes a little more. Yeah,
I don't know how to. Yeah. I think now I am more seeable. I don't know. I've just seen.
No problem. So please keep talking. I was trying to locate where it was coming from. So the thing is that we actually did on 1,020 patients, and we captured the data, which is so one of the reasons perhaps they were on telmisartan. These are hypertensive patients, and the cardiologist felt comfortable using telmisartan. And the other thing which we found that some of them were earlier on telmisartan. For example, somebody on telmisartan for hypertension gets admitted with an acute MI, and you reperfuse, and they perhaps continued that. But all said and done, the guideline-directed therapy, ramipril was the most common. In fact, lisinopril very, very seldom used, and the commonest drug beta blocker which was used was metoprolol. Maybe, as you rightly said, it's a pen habit also. We do not know. So, are you able to see my slides?
Can you hear me?
Yes, I can.
Yes, sir.
Please
we can see your slide.
Okay.
But now I think the slides.
Right. As per the clinical. Yeah.
Sorry. 1 second. Rishikesh, if you can just share the panel discussion slides. There's some problem at my end.
I'll share.
Go on. Please go on, please.
Yeah, sure. As per the guidelines, ACE inhibitor is the only drug, and if the patient is not tolerable to ACE inhibitor, ARB is the second line drug. It is the second line drug. There are few trials also has clearly in the result shows that if you start ARB in acute MI, it shows deleterious and detrimental to the acute MI. There is they have even given some of the reasons why you should not start telmisartan or any of the ARB in acute MI for a couple of days, at least for 30 days. If you give ARB in first 30 days in acute MI, it shows that the infraction is increasing. You have any comment about that, sir? Jayagopal, sir?
Yeah. I think the infarct expansion was a theory which actually you are right about that. And there was also initially when this got introduced, I don't know whether you're, because this is supposed to have an effect on the PaI2. So the hypercoagulable state was supposed to be increased with this drug, the ARBs. And that's why the concept of ARB paradox came in. I don't know whether many people really attribute then. So this was done. And then when the drug was marketed, in fact, many people felt that this is not the way to go, but and a little higher incidence of MI, even in people without an MI. But then subsequently, large trials did not show this. It did not, as you rightly said, you can always tweak your statistics. It was not found to be statistically significant. They said there's nothing wrong with it. But I fully agree, endorse with you, your viewpoint that I think we have sufficient data to say that ACE is superior. And not only that, I think I'll go one step further by saying that, because this has an effect on atherosclerosis. In fact, there is a data which has shown that even when you stent a patient and somebody has a normal LV function, it has an effect on the metalloproteinases. So the ACE inhibition, if you're able to administer this drug, it will take care of the neointimal proliferation and the stent restenosis part of it has an effect. So I think this is a concept which came in, and today there is data to suggest that this is a very small study where those patients who were stented on Ramipral vis-a-vis another thing, but then those on Ramipral had a lesser event rate. Today, I think with all the drug-eluting stents, I think perhaps it's not a very important thing, but I think that is there too. So I think unlike beta blocker today, we can have sufficient data to say that even with a normal EF, hypertensive, you can still use an ACE. So, and again, the tissue specific, that is where Ramipral perhaps has a slight edge over. Jabir, I was discussing about our post-MI prescription pattern studies where we found that telmisartan was being used in a much higher number. And of course, Ramipral is the drug. In fact, I don't have the data right now with me. We are actually preparing it for a publication. So it's all written up. And then, of course, this was presented in the ACC. And so if somebody is interested, you can see this in the JAC Abstract History publication also. Do we have the questions,
Dr. Jagopal, I think, I don't know why, despite all the data available, can you hear me?
Go ahead. Yeah.
Despite all the data, most of the data, especially in ACS, atherosclerosis, progression prevention, heart failure, all favors ACE inhibitor. Somehow people are worried about ACE inhibitors, maybe the cough or the tolerance of ACE inhibitors. The prescription is coming down like anything. And you also know the data in heart failure. The ACE inhibitor use is much, much less.
Can I answer, sir? Jabir, sir?
Yeah, please.
Right. The heart failure, I agree and everybody agree because Arni has taken the driver's seat, no doubt about that, because there are so many trials which proves that Arni is much superior than head-to-head trial where Arni versus ACE inhibitor. So in heart failure, yes, we cardiologists have shifted from ACE inhibitor to Arni. Second is in acute MI, how many percentage of we have seen for last 21 years, I have seen that ACE inhibitor I am prescribing in acute MI, hardly less than 1% of the patients are coming with a dry cough and intolerable cough. First thing is, if you educate or if I educate my patients that the cough is a minimal, it will get rid of all this thing. Patients are comfortable. Only thing is how we are educating the patient. All the data is very clear. First 30 days ACE inhibitor is very good, even if LVEF is less than 40 or more than 40. Less than 50 is 100%, it is useful. But I think cough in ACE inhibitor is hardly 1%.
Absolutely right. I think very less amount of it. It's just a fear. And even if the patients are facing, most of them are smokers. Even the smoker's cough is attributed to an ACE inhibitor.
Absolutely.
If the patient develops a respiratory infection, people will stop the ACE inhibitors. That's a problem.
Absolutely.
And second thing is,
Absolutely.
in acute MI, as you rightly pointed out, the Paradise MI trial could not prove a superiority of the Arni over Ramipral. And we have the older data of the AIR trial. That is the first data with the best data available with the ACE inhibitor in acute MI. I think it was the LV ejection fraction less than 40% where they used. I don't exactly remember the details.
We just presented it. We just showed it here.
You just now showed
You're
it.
absolutely right.
Right.
Yeah. Sambat, yes. Can you just run the slide, please? Next, so Dr. Sambat, please carry on. Next slide, please.
What is the role of enalapril as such on today's practice? We are giving so much importance to this thing. What do you think will be the role of enalapril as such in these type of
It's a
settings?
good drug. I mean, I pursue it quite a lot, but then if you have to really use it, you have to go minimum of 5 milligram BID. So that's number one. It's a twice daily drug. And then the second thing is that it's a very cheap drug. So I think for all my poor patients, I still rely, and this is available free of cost. At least in Kerala, all the government setup, it's available.
That's the same situation is for me, Jagopal, here, because it's opposite to government hospital I practice. So most of the patients come from government hospitals. So I just ask them to continue that.
Absolutely.
That's why
it's a time-tested drug. So I think the first oral drug which we really embraced was enalapril, much before ramipril. Because I still remember we were uncomfortable with captopril. I told you, because when this was introduced, we used to make the patient sit in the OPD because first dose hypotension was a worry. Whereas when enalapril came in, that was that. And then we started using even with 100 BP, we were confident to start with a 1.25 milligram BID, gradually step it up. And one important thing we learned was, you can gradually, but even if you have a BP of 100, just like Arni, you can slowly build up and get the patient on the desired dose. And if you look at the HOPE trial also, the hypotension effect is only an additional 2 to 3 millimeters. So it's a question of getting used to that drug.
Yeah.
And,
very rightly said.
And the post-MI patients.
These questions are to you, Jabir.
And the post-MI patients with the posterior vascularization, always interventional cardiologists would like to keep a systolic blood pressure a little high for the pressure head in the stent so that the stent should not get occluded. So I'm comfortable with a blood pressure of 100 millimeters of mercury, and safely I'll start ACE inhibitors if the blood pressure is more than 110. And it's a little rapid up titration. We are going ramipril. We start with 2.5 milligram. After 3-4 days, if the blood pressure is stable, before discharge, we'll step up to 5. And the first visit, if the blood pressure is still more than 100 and no evidence of symptomatic hypotension or organ hypoperfusion, we'll step it up to 10 milligram. And titration is a little rapid titration. Now, everywhere it is rapid titration, even for ARNI. ARNI, they have found that you can up titrate the drug and reach the target dose in 10 weeks of time in the titration trial. So if we are careful, volume status is well maintained, I think we can step up the drug to the maximum tolerated dose or the guideline recommended dose of 10 milligram for ramipril and 20 milligram for enalapril. That can be done in 2 weeks' time.
Yeah, but Jabir, just a question to you. I think you rightly pointed out how we go about doing this. But I think the only real concern for us is a diabetic patient with a CKD. And then, they come to you with a creatinine of 1.6. You use some contrast. Next year, the creatinine starts going up. Let's say 1.9. I think a word of caution there. Perhaps, we're all... I think this is something which the physician should realize.
Right. If the slope of creatinine is on a rising trend, always better to hold this drug for some time. And once the creatinine stabilizes, we can gradually reintroduce. And hypovolemia should be prevented in these type of patients and reduce the dose of diuretics if it is not essential.
Maybe I'll ask another panel member also, Dr. Sridhara. The question now, the thing is that we all talk about an early discharge. I don't know how it's in your practice. I think most of our MI patients, we tend to discharge them early. So the question of up titrating, does it really come in because they are no longer an inpatient?
So in our center, sir, it is, as you were pointing out now, in any corporate setup, it is a primary PCI. So once a primary PCI is done, I think the stay in the CCU, depending on the clinical stability of the patient, is hardly 1 or 2 days, not more than that. So in the first 24 hours, definitely we are starting ACE inhibitor in our center. And, once the stability happens, when the perfusion is good, the blood pressure is reasonably okay, and the electrolyte creatinines are fine, is out of the hospital in the CCU to the ward. Our discharge time for a stable MI, irrespective of the ejection fraction, unless until it necessitated inotropes or some sort of a ventilator or some oxygen requirement, is hardly 3-4 days. So what we are doing is a 2.5 milligram of ramipril we start off, and maybe at best, if we can add beta blocker as well, or some aldosterone antagonist, etc., it is, I mean, we are not able to discharge a patient beyond 5 milligram of ramipril, depending on the blood pressure. That's what it is in 3-4 days. Of course, when they come for follow-up, we can have a review, relook, all those things.
Absolutely right. I think perhaps it's a very common, I mean, practice where, because we all tend to discharge them much early these days than what it was earlier days. So I think the message here, I think, to the audience or the physicians is start early and just be on the lookout for red flags like a rising creatinine or maybe potassium once in a while. But otherwise, I think it's mandatory that we follow the guidelines. Can we have the next slide? Next question to the panelists. Dr. Ravishankar, the question is...
already I have answered. If the patient is having hypertension and developed acute MI, he is hypertension on ARB, I certainly switch to ACE inhibitor post MI for at least for 30 days. Once the patient is stable and LV is stable, and even though in the post MI with a good LV function or fair LV function also, I switch to ACE inhibitor. And I think I will start with the 2.5 ramipril and then slowly increase the dose also. But certainly I will switch to ACE inhibitor. The reason also I have discussed, I think that is very clear from my side.
And your preference is definitely ramipril to...
Ramipril as of now, because I am quite happy with enalapril also. But somehow my hand is coming for ramipril. I am happy with ramipril. Enalapril also is...
Lisinopril? Do you use lisinopril at all?
Lisinopril as of now, very less. When I was doing my DM, we have used so much of captopril. Only one reason is it's a short acting.
Right. So the other thing which is very interesting, for example, for us who practice in Kerala, we used to get a lot of people from the Gulf, and those were the days at least about
exactly.
20
I just want
ago.
to tell, lisinopril is plentifully available in Gulf. Lisinopril is and perindopril also available.
Yeah, so, I was about to say that.
Perindopril also available. So, but ramipril, we have so many data is available. That's the reason we are having an institute where DNB cardiologists also there. So we are following absolutely guideline. And I have seen in my practice also, ACE inhibitor is doing extremely good in post-MI.
Yeah, the only for 30 days. The only advantage of lisinopril is its long-acting action.
Correct.
So
I don't want to. Actually, I don't want to give a long acting for at least for first 10 days or 15 days. I don't know the patient will be tolerate. So after 30 days, yes, I can switch over to ARP.
Thank you. So I think that is quite informative. So I hope any different opinion from the panel members?
Sir, I mean, if you have to act as a devil's advocate, what if the blood pressure medication was valsartan?
Sorry?
What if the blood pressure medication was valsartan? I mean, I'm asking only valsartan for blood pressure he was taking. Still,
so
we will change it over to
post-MI. Absolutely, I will change over, sir.
Valsartan. Ramipril,
I consider it's a only ARB. So I changed to ACE inhibitor as of now. And post-MI, heart failure, ARNI also has got no role or equivalent to ACE inhibitor. At par with the ACE inhibitor. So RNA role also in post-MI acute or heart failure also is not significant as heart failure with the reduced dissection fraction in congestive cardiac failure.
I think I agree with Dr. Ravishankar because, post-MI, the data is strong. Even if they are on valsartan or one of the approved drugs, it's fair enough from our side to switch over to ramipril, but that's what the recommendation is. But I think it's also the clinical judgment. For example,
clinical judgment is absolutely right.
So for example, I know people with a normal LV post this thing, they get telmisartan free of cost from somewhere, and then the question is whether some ACE is better. I mean, ARB is better than ACE. But I think strictly from a scientific perspective, perhaps we should go with the ACE inhibitor for first few weeks at least. Can we have the next slide? Dr. Sampath?
Yeah. This usually, as Dr. Ravishankar said, I do not start them immediately. I just wait for a month or so and then slowly start titrating it after stopping the ACE inhibitors. Once I start them on ACE inhibitors, I continue for about Actually, 6 weeks I continue that. Then only I start them on an RNA and seeing the ejection fraction and all those things. And if they tolerate AC inhibitors well, I try to continue that only. I do not switch over directly to RNA at all. Patients with an ejection fraction of 50 plus, I do not change it just like that. Patient less than 50%, I directly try to restart with an RNA once after 6 weeks.
I'll just put a different question to you. I think this is something which I asked many people. So your patient has an EF of 35% at the time of discharge, and you have revascularized. He's on Ramipral 2.5 milligram BID. 6 weeks, 8 weeks down the line, his EF is 45%. So would you continue your ACE inhibitor? Would you switch over to RNA?
I'll be happy to switch over to RNA if his blood pressures are maintained and if he's able to buy it. And second, if its EF is 50, will you continue ACE inhibitor? Will you put him on RNA? I would definitely. He has already improved, because I'll give you a scenario where people have come with an EF of 25. We have been seeing patients for ages now with ACE inhibitor, EF 25. Now they're doing well for the last so many years with an EF of 45%. Do you think it's rational? 20 years or 25 years on ACE inhibitor. But the data says today RNA is the go-to drug for any LV dysfunction. Yeah, so Dr. Jayagopal, as you rightly say, if he's on RNA for many years, 10 years or 8 years or 10 years, 15 years, he's comfortable, I will definitely continue ACE inhibitors. I would not switch over to RNA. I will not switch over. That's a real, I think, pearl of wisdom from, senior cardiologists. I think it's important to understand that somebody is doing very well. There is no need to, and from all practical reasons, the EF has improved, patient has tolerated the drug very well. Just because you have a new drug in the market doesn't mean that, RNAs have really shown, because I think the data is also very overwhelming. So the PROVI trial was a trial which has shown that average improvement in EF with this drug is close to about 9.3%. So no drug has shown an improvement of LVF. And for all of us, for sure, we'll vouch that the quality of life generally is much superior with RNA. So I think there's a case in point here. Initially, ACE inhibitors, maybe depending on your judgment, 6 weeks or 4 weeks, or even once a patient is stable, if they really deserves an RNA in terms of a low EF, maybe the right time. But then there's also, I think, another question, maybe Dr. Sridhara can now different perspective from cardiologists today. In fact, I also sometimes now try to fit into that role. I'm not saying that it's a negative, I thought. Patient comes to you with acute heart failure. We all know RNA is the drug to be. De novo, if you really want to, if it's an RNA naive patient, let's say, and then at that point of time his blood pressure is 170. Some of us are comfortable. We don't want to start him on ACE. Then you have to discontinue for a couple of days and then restart, right? Instead of that, some of us think that why not you start on a small dose of valsartan and then switch over to RNA later on once the blood pressure comes a little higher up. So do you subscribe to that thought, or you think it is?
No, sir. If it is acute heart failure or something like that.
No, I am talking about not an MI situation.
Chronic heart failure. Any heart failure. Any heart failure therapy, if one of the pillar, if I have to choose between ACE inhibitor or RNA in a borderline blood pressure situation, rather I would, if I am not in a situation to upfront start RNA, I would rather start an ACE inhibitor, and then if I'm very comfortable and I get convinced that I have to start RNA at some point of time later down the line, stop it for around 48 hours and you can always start RNA. That's what is my take. If at all, if I have to choose.
Yeah, Dr. Ravi?
Yeah. I would rather prefer to give 25 milligram BD if RNA start with rather than valsartan. There is a very clear cut. Even 25 milligram RNA also proved to be better. Then once the patient is tolerable for the 25 milligram, then I can increase the dose to 50 milligram BD.
Yeah,
I have seen also, I have started in ADHF patient about to discharge. I have started 25 milligram with the blood pressure 90 also. Patient is well tolerable. So it is only our mindset that we have to, even though patient is BP systolic 90 plus, I am happily to start with RNA. But only thing is I am educating the patient not to move outside this. Once after 10-15 days patient is coming to me, I am very clear that patient BP is improving, patient symptomatically quality of life also improved.
Yeah, I think so. I think the message is some RNA is better than no RNA, number one.
Correct.
Number two, yeah, it's a question of whether you are symptomatic hypotension. If you're not symptomatic, I think it's worthwhile to continue RNA. But I think this is something which we have seen when we looked into the prescription patterns. We have seen that, in the periphery, some of them, they're scared about using this drug. In fact, if you look at the challenges of guideline-directed therapy, why the physician prescribed, there are three challenges. One is hypotension, second is a renal dysfunction, third is hyperkalemia. So these are the three things which we are trying to see and how best you can overcome these physician barriers to therapy. So this is what we are really looking into, and that's one time when we found that some of the people have a concept of starting on valsartan. Well, that's perhaps not the way to go about. Scientifically speaking, RNA is the choice. Can we have the next one, please? Dr. Sridhar, this is to you.
So post-MI, definitely, I mean, other panelists were concurring. In the initial few weeks to few months, my choice of drug is ACE inhibitor. As long as the ejection fraction is less than 50%. There is absolutely no doubt about it. In fact, in the RAASi trial, the curve started widening significantly, though it was not a significant difference in favor of RNA. Was only at around 2 to 3 months, the widening started more and more there. So in my practice, I wouldn't consider RNA at all in the first 6 months of any post-MI treatment, but I still consider post-MI rheology as something different from chronic heart failure or acute heart failure of other etiologies. Maybe post 6 months, maybe that is the period when, the fibrosis, if at all, if it has to set in, or whatever remodeling effects or something like that. If I am concerned that the EF is not improving, or patient still has some symptomatic heart failure of whatever class, I may switch over to RNA. Not in the initial few months and few weeks, definitely.
Thank you. I think we have discussed this at length. So the next one, please. Any further? So I think this can be discussed with everyone. Post-MI, post-revasculation, we were talking about ACE, but then question is, when do you start a beta blocker? I think sometimes some of us can even enlighten on the role of beta blocker. Now the ESC just got released a few days back. And which is a preferred beta blocker? At what dose do you initiate? How do you uptitrate it? And finally, of course, a combination of an ACE plus a beta blocker, which is perhaps what the industry is also interested in. Dr. Sampath?
Yeah, Dr. Jayagopal, most of my patients after 24 to 48 hours at the time of discharge, they'll have a bisoprolol 1.25 milligram BD, to be very honest with you.
Right.
I am not staying against it. I just start them on this 1.25 milligrams because that's the dose which is available with me. But particularly when the ejection fraction is poor and he has got tachycardias of heart rates more than 80s, 70s, and 80s, I would prefer them to be on a beta blockers, right, along with an ACE inhibitors.
And your preferred choice is bisoprolol.
Bisoprolol, yeah.
Yeah, it's a wonderful drug because the beta-1 selectivity is also really great. So, Dr. Ravi Shankar, what is your preference? And when would you start?
I agree with Dr. The panelist, but my preferred drug is beta blocker, bisoprolol only. But I always start within 24 hours. If the patient is not so much of wet, it is a dry patient, is not Krebs or acute heart failure is not there, 100% I start within 24 hours. If the patient is in heart failure, yes, I will wait for after 24 hours, but within 24 hours, I start with 2.5, hardly matters. And in ICU, patient is there in ICU. And yes, of course, previously I used to give metoprolol, now slowly switching to bisoprolol.
I think
and
perhaps
ACE inhibitor, ACE inhibitor is, of course, ACE inhibitor ramipril and bisoprolol. And post follow-up, maybe 1 or 2 months, I start with ACE inhibitor and beta blocker combination.
So in that questionnaire, there was no specificity about MI. I mean, the situations may differ. If it was an inferior MI, you have transient CHB, prolonged PR. As such, even after revascularization, there are a couple of patients where there is bradycardia. In such patients, definitely, I mean, beta blocker.
No contraindication, right?
Yeah. And if it's a large MI interval, there is LV dysfunction. we'll definitely start beta blocker post 24 hours when once you have initiated the AS or something in the initial 24 hours. And I usually start off with the extended release metoprolol succinate. That's what is my choice. Lowest doses, maybe 12.5 BD or something like that, and slowly up titrate. And as far as the combination of ACE inhibitor beta blocker, I know there are a lot of noise in between a month or twice before that. It's all banned, something like that. So many patients came back to me saying that this combination is banned. I'm still not very clear. I want to understand what has happened to the combination of beta blocker and ACE inhibitor. And there is still some perception that this combination is banned. That's what is the combination we could otherwise be a very big help to economically to the patient. I don't know what is the take of other panelists.
Jabir?
It is not banned. I believe Cadesmeto is available with MCure, I believe.
Yeah, combination
Ravi,
available with
I think
MCure.
Ravi, right now they are out of stock. I think they will be coming back. I think so.
Oh,
There is one
correct.
combination of
Still-
metoprolol. We have a metoprolol combination, isn't it? A
Yeah,
metoprolol
Jagmeet,
combination.
there's one. There's Hope is empty. That the micro fillers have got that.
No,
No,
even
Cardase Meto is there, you know, the
This
Cadesmeto is
Cadesmeto?
there. I used to write a lot. Now it is maybe stocks are not available.
Dr. Jayagopal, this Cadesmeto was first introduced, then they withdrew the drug and reintroduced later.
yeah, it is still being used. In fact, we have
They withdrew
actually
in between. They withdrew because of the decrease in the prescriptions. Now they have reintroduced. That's a good combination. Once we stabilize the patient.
Right.
Once we
2.5,
stabilize the
25.
patient, on this fixed dose of beta blocker and ACE inhibitor, I think we can shift to the metoprolol plus the sustained release metoprolol plus ramipril.
And there's also one more thing, Raj. There recently there's a combination of perindopril plus bisoprolol.
Oh, okay.
Both
Yeah.
long acting.
Right.
So
It's
that's that's also available.
And it's a truly one-sided drug.
It is really one-sided drug. That's the advantage. Whereas ideally metoprolol and ramipril has to be given twice a day. So that's one of the disadvantages. In fact, when you look at that, theoretically speaking, post-MI, you have multiple combinations of telmisartan plus any beta blocker. Unfortunately, hundreds of companies marketing that. Whereas, as you rightly said, we would love to have something with ramipril or, but the scientific rationale combination is not there. And of course, up titration is also difficult. Anyway,
I think this new combination of bisoprolol with this thing is perindopril is good.
Yeah, Coseryl. So that's in fact, there's only one company which has right now. I think we've been using it. So I think we have a few questions. Rishikesh, maybe you can share to clarify on the ban part, ramipril, metoprolol for immediate release. Yeah, the metoprolol, I think the metoprolol succinate is the one which is short acting. In fact, that's what I was trying to tell you. I had my personal experience with metoprolol succinate. That is your IV beta log. That was the first innovative brand which was available way back in 1984. I think I used it. So this is a drug which has stood the test of time. And what we were actually administering them as postgraduates. We had to administer them during intravenous during an acute MI. And then we found that this was actually the 5 milligram, 1 milligram per ml, 5 milligram, 3 doses based on your blood pressure and heart rate. And this actually did reduce the arrhythmia burden. Yeah. And in fact, this is what we've seen input. When you're in the context of primary, somebody comes to you within 1 hour of MI, he throws VT, VF. People start bombarding them with silocardia. I mean, it is not the way to go about, but it's not a good drug. Amiodarone. Well, you use, if they have sympathetic tone is higher, they have high blood pressure. The drug which will beautifully work is IV metoprolol. So as a initial immediate this thing, that's succinate. But all the data that has been generated, unfortunately, is with tartrate. We don't have data. So the extended release tartrate, we have initial just like beta Loprozar XL was the one which is available all over the world. So that came as an XL, which is a succinate. So succinate is sustained. So that's how I remember. So that is the one which is approved, and perhaps today in our practice that is what we need to utilize. So finally, a good question. I think this can be put to all the panelists here. Do you think NT-proBNP would be a useful marker to choose an ARNI over ramipril? What do the panel members think about this?
No, Zubir
Dr.
sir.
Jayagopal, do we really have a data which can tell us whether we can choose ARNI over Ramipril with NT-proBNP? We don't have a data, but logically speaking, if the NT-proBNP is high, the prognosis is bad. So we should use the best drug possible. And there I may shift from a Ramipril to ARNI. And more than that, now it's a classical indication for shifting from ACE inhibitor to ARNI in all patients to improve the additional benefit if they can tolerate ARNI.
That is in
Heart failure.
which you are treated, decongested, and then, I mean, if they can off IV diuretics. But then in the context of MI, does it really matter? Suppose you have
In
a
the
let me
context
put a
of
question to
MI,
you.
in
MI,
the
post
context
MI
of
second day, NT-proBNP is 1200. Will that make a decision in changing over to ARNI?
right now with the Paradise MI data, in the first 10 days or first 2 weeks, I would prefer ACE inhibitor rather than ARNI.
Yeah, so the Pioneer HF
Right.
trial was a trial which showed that there is a reduction of NT-proBNP. Any drug which is useful, which is in reducing the NT-proBNP, has to be superior. So I think nobody really argue. I mean, goes against that data. But the issue in post MI is still again Ramipril. Agree? Do you really need, the question so comes to you, whether do you really need an NT-proBNP post MI?
Yeah, that is the question I wanted to ask. Why do we need an NT-proBNP at the acute MI situation?
This is now considered NT-proBNP is also considered as a cardiac biomarker. Recent guidelines also shows that you have to do it NT-proBNP. That's a prognostic marker. If the NT-proBNP is more than 4,000, 5,000, 10,000, that means prognosis is little bit bad. So I don't think NT-proBNP is a deciding factor because NT-proBNP is higher. Definitely I choose for RNI. Even if NT-proBNP less also, I prefer RNI in acute MI heart failure. Sorry, Ramipril.
Okay, right.
Ramipril.
So I think so that's a little out
In
of place in the
post-MI,
context
right.
of AMI. Yeah, NT-proBNP.
Right.
Dr. Sampath and Dr. Sridhar, will you start ACE in all patients with ACS, whether revascular is performed or not, to get the mortality benefits?
Answer is yes, sir. I mean,
I think
nowadays,
you answered this already.
Yeah, you answered this. And revascularization is performed in most of the patients in the present situation.
Yeah, most of them, all of them, not most of them, in fact, all of them will be receiving some form of ACE inhibitors, particularly whether revascularization is done or not. Definitely, most of them will be on ACE inhibitor if he is qualifying for it. If he does not have a renal failure or anything, definitely he should be on ACE inhibitors.
Rishikesh, we are slowly running out of time. If you can just run through any slides. Finally, what percentage of patients tolerate ARNI 200 BID versus Ramipril 5 mg BID? So I'll answer that. 200 mg BID.
I think
is just 5% of my
Jayagopal will be an ideal person to answer this because he's done lots of heart failure trials.
So we in our practice it's less than 5%, 200 BID, and the commonest is 100 mg BID, and of course a substantial proportion, about 30 to 40%, around 50 mg BID. And I cannot negate there are people on 25 mg, which is again maybe around 5%, but that's the truth. But Ramipril 5 mg BID, perhaps 60 to 70% of our patients, but 2.5 mg probably the standard dosage which is being followed.
Yeah.
Rishikesh, do you want to share something in the chat box? I think for the audience, get the expert panel viewpoint. If you can just show the chat box also, it's fine. Or you can just read it out.
Yeah, so you can read it out. Are you able to see the question, sir, at the bottom?
No, not really. You can.
Okay. So there is just one clarification, sir. Like on the ban part you mentioned about Ramipril and metoprolol. So that ban was for immediate release, but in Cardes Meto we have extended release formulation available, and that's why Cardes Meto is freely available across India.
Okay, but there are 3 other questions. Do you see any role of ACE inhibitors in younger hypertensive patients for long-term? So we are going to the HOPE data. So the HOPE data was actually beneficial, but then the question is, so I think we should ask the panel members, what do you think? Because basically all these are effective in high renin population, right? So what do you think about the Indian population? Do you think they fall into, we have some data, whether low renin, high renin, or? So do you use ACE inhibitors in all your younger hypertensives?
Young hypertensives, most of them are really not on ACE inhibitors. Most of them, I really start them on ARBs, to be very honest. Very few selective patients are on ACE inhibitors.
And your preferred one is telmisartan, because that will answer the second trial, on-target trial question.
Yeah,
So,
75 to 80% of them are on telmisartan.
And what about olmesartan? Do you believe in that? The roadmap trial did not show data.
Yeah,
It
did
was a
not
negative
support
data.
it much. It was a negative trial. I don't know what the panel says.
Dr. Ravishankar, what do you think? Current scenario, do you prefer, or how do you see the role of ramipril high CV risk patient?
I always prefer for young hypertension, no comorbidities. I prefer ARB, and most preferably 70 to 80% telmisartan.
And there are this white coat hypertension young individuals. In Indian scenario, in fact, with India.
In that case, most of the Indian population with young hypertension, there are some, the sympathetic activity is more. So in that case, I add some beta blocker 2.5. We have a combination 2.5 and 40 milligram of telmisartan. I always add 2.5 some bisoprolol or metoprolol 12.5 or 25. They are doing good. So increased sympathetic activity, usually I find in young hypertensive, where heart rate is more than 90, I always add some beta blocker.
Dr. Sampath, and finally, Dr. Sridhar, if you're there,
Yeah,
any closing comments that you want to make? Because I think we're short by about 6 minutes.
Oh. I think we have covered most of the posts. I think we can end up now itself.
Right.
Thank you so much. So I think I would like to thank all the panel members and also MCure team also for having led us all into this very lively session in the evening. So hope the audience got some kind of an information, and also this is basically to stress the importance of ACE inhibition post-MI, and all of us unanimously think that the immediate post-MI, the way to go about is ACE inhibition, and preferably the tissue-specific ramipril is the way to go about. Of course, it's not just one drug. The guideline-directed therapy also would suggest metoprolol in addition to the DAPT and statins, which are the order of the day. So ARNI, as of now, once you pass the acute situation and once they are if you have an LV dysfunction in the chronic setup, it's proven its role. So I think with that, I would like to end the presentation here, hand it over back to Dr. Rishikesh to do the final take home and the vote of thanks.
Thank you,
Thank
sir.
you,
Thank you for summing up the discussion well, sir. I would like to express my sincere gratitude to our esteemed moderator, Dr. P.B. Jayagopal, sir, for delivering the excellent session today and driving the interesting panel discussion. I would also like to thank our expert panelists, Dr. Jabir Abdullah Kutti, sir, Dr. A. Sai Ravi Shankar, sir, Dr. Sampath Kumar, sir, and Dr. Sridhara ji, sir, for sharing their knowledge and wisdom with us today. I would also like to thank our esteemed audience for their time, continued love, and support for Cardio Colloquium program. On behalf of MCure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at MCure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Good night. Thank you.
Good night. Good night.
Good night.